Dr. Bott cannot be here today, but I will try to do them justice. Our objectives are to describe and understand the clinical importance and utility of comorbidity of opioid use disorder and pain in their treatment. Understand how treatment for opioid use disorder does not preclude the need for effective pain management, and to describe and apply strategies to manage pain in patients who are on treatment for opioid use disorder. So we're first going to talk about prevalence. There's been several studies looking at the prevalence of co-occurring OUD and chronic pain over the past few decades. And you can see that there is a range spanning from 37% to upwards of 64%. So it is quite prevalent for both to occur. This relationship is bidirectional, but often pain comes first. In this study looking at over 5,000 patients with OUD, 35% reported no pain. Close to 10% reported having opioid disorder first, followed by pain. About 15% had OUD and pain at presentation, but close to 40% had pain first and then subsequent development of OUD. And for patients who had chronic pain before the onset of OUD, there were also higher rates of mental health conditions and other health conditions. So also for patients who have OUD before the onset of pain, we see oftentimes other co-occurring substance use disorder, and then higher prevalence of infectious disease, namely Hep C and HIV, that can present also in higher prevalence along with OUD. So we're going to talk first about acute pain management. This, I believe, is a slide that was on the web, so free range on the web, that it was placed here for depiction of a patient's experience of their acute pain and how uncomfortable that was. So we'll start with a vignette. AN is a 45-year-old female status post shoulder surgery. She has a history of OUD and was previously treated with methadone twice. When she stopped treatment, both times she did experience relapse. She was using a 0.5 gram 2 to 3 times a day of heroin prior to surgery. During surgery, she was on morphine, continuous infusion with breakthrough pain doses, last dose 2 hours ago. And she requests more pain medication. She reports that she was in pain of 9 out of 10, very tearful. Her vitals were stable. And the nurse came and approached the providers with this quote: "She is drug seeking. She's already getting more pain meds than any other patient in the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen her addiction." So some commonly held beliefs. Acute pain is frequently undertreated, up to 60% in inpatient settings, and even more so in patients who are experiencing substance use disorder. And really, there's a large amount of work we have to do, both in medicine and beyond, to address the stigma with substance use. It's seen by healthcare professionals as primarily a social problem requiring law enforcement rather than a health problem requiring prevention and treatment. That's from a paper from 2014, but oftentimes there is still that sentiment in some providers. And there's this perceived controllability that then equates to blaming the patient. So when patients are often seen as manipulative or manipulating providers to perhaps seek substances as opposed to actually needing the medication to treat acute pain. So what is a suggested approach? Accepting the patient's self-reported pain, right? So understanding that pain behaviors will vary widely and that vital signs, so for instance, in the patient's case here, whose vital signs were stable, they're not always a reliable indicator of pain intensity. And then considering that there's addiction versus pseudo-addiction, so patient actually has their pain is not treated adequately and they actually need increased doses, versus physiologic dependence, so they're at risk of withdrawing if not having the needed dose of medication. And if it's required do not withhold opioid analgesics from people with addictions, because there's no data showing that acute pain management is going to worsen their addiction. That's sometimes a provider's concern, right? And so what we do know, though, is that untreated pain is likely to, in addition to making the patient's experience worse, also increase cravings and subsequently increasing risk of relapse. And 2 studies in patients who were on treatment on medication management did not show that opioid analgesia for acute pain increase any chances of relapse. It's also important to remember that because of tolerance to opioids, that they may actually need higher doses than patients who are not on maintenance treatment with methadone or buprenorphine in acute settings. The risk of respiratory suppression may be lower in patients who are opioid tolerant, but it is still crucial to monitor closely their effects. So just to remember that opioid agonist treatment will treat their baseline opioid use disorder, but it won't treat acute pain because they have that for maintenance, and their need for acute pain management is on top of that. So there's some slides here that are looking at management of pain in the emergency department. So it's you can see here on the left that there's a column that can be used as a guide, but always want to consider at first, certainly if your patient is presenting and they have been on maintenance buprenorphine, to continue it. You might consider dividing the dose into every 4 to 6 hours, as that can sometimes help treat pain more effectively, but also considering non-opioid analgesics if appropriate, and things such as ice and immobilization and SEDS. And then the alternatives to opioids are alto, such as trigger point injections, regional blocks, lidocaine, gabapentinoids, etc. So, and then continuing with the column on the left, there's more advanced regional nerve blocks, subdissociative ketamine, and our alpha-2 adrenoceptor agonists such as clonidine. All of these, again, would just be in the acute ER setting. And then you can see here that once we're through this acute setting, titrating down to their maintenance dose of buprenorphine is certainly something that, unless they were on a subtherapeutic dose, that is something that would be recommended. And then continuing with our acute pain management in the ER, it's particularly important to be comfortable with these non-opioid techniques of pain, in part because of that high opioid tolerance in patients on MOUD, that other techniques may be more beneficial. Also remembering that in our patients who are on naltrexone, this medication has a very high, and you might usually for naltrexone, you might be someone who has alcohol use disorder presenting on naltrexone, so how to treat acute pain in that setting. And it may be difficult to treat with most opioids due to that high binding affinity. But in the acute setting, medications such as fentanyl or in some situations, hydromorphone may be beneficial. And then buprenorphine also has that high binding affinity. So again, that option 1 of fentanyl or hydromorphone may be helpful. And then methadone, again, is a long half-life full mu agonist. And so it certainly should be continued if possible in the emergency setting, but might need acute, again, treatment on top of it to adequately treat the pain. So what do we do when patients present on methadone? It's important to verify the dose from their home clinic. However, if that dose can't be verified, it's safer to break up the self-reported dose into 3 to 4 times a day dosing rather than giving it all at once. And then if as needed, adding in the short-acting opioids for breakthrough pain. Depending on the patient's length of stay, then gradually increasing the methadone dose, especially if That helps with any sign of withdrawal from their prior dosing regimen. It may also help with ongoing pain. Of course, don't want to administer buprenorphine because with its partial agonist high affinity effect, that can precipitate withdrawal, will precipitate withdrawal in someone on methadone. And if someone's unable to take their oral dose, they can be given IV methadone, but that dose should be reduced to 1/2 to 2/3 and given in divided doses. Again, methadone for analgesia is multiple times a day dosing. It can be prescribed by any clinician with a Schedule II license. However, we definitely, because of the long half-life and variability of methadone and high risk of overdose, it's certainly not recommended long-term if possible to avoid that for pain. Methadone for opioid use disorder is typically once a day dosing and only through an opioid treatment program. So now turning to buprenorphine and acute pain management. Again, we want to use all of our non-opioid modalities as possible for pain management. And then if possible, we'll adjust the buprenorphine dosing interval as there's some evidence that more frequent dosing has better coverage for pain. So for instance, in someone who, and these are relatively low doses, perhaps of buprenorphine these days, but in someone who's on 12 milligrams a day, we could divide that into a 4 milligram 3 times a day dose, etc. 16 milligrams could be four times a day. And you might also, if able, consider an increase, at least temporarily, in their dose overall. So if someone's presenting who's normally on 8 milligrams twice a day with acute pain, they could benefit from an increase in that dose, perhaps to 8 milligrams 3 times a day. It is worthwhile to consider IV buprenorphine and also to augment with the short-acting opioids that have the high mu receptor binding affinity, as seen in the prior slides. Fentanyl and Dilaudid has a longer acting effect, but is less titratable. And then certainly, if needed, consider consultation with addiction medicine. So we're going to talk a little bit about perioperative management. There's still some lack of consensus, I guess, in the medical community in general. We are trying to keep people on buprenorphine. But because of that lack of consensus, that decision is often based on the preference of the surgical team. But certainly if there's a chance of communicating with them ahead of time, that could be helpful. A lot of patients fear talking with providers because of fear of mistreatment. A lot of providers fear deception. Perhaps they think that they're going to, again, as before, contribute to their substance use if they continue it. So there's room for discussion there. And so in the pre-op time, confirming multi-party consent and coordinating care with other providers, that communication is always helpful for best care and safety. But in general, again, buprenorphine should not be discontinued. Some clinicians might lower the dose to 8 to 16 milligrams a day. The thought being that you're kind of opening up more of that mu receptor availability, but it's also been shown to be effective to continue their maintenance dose and treat on top of it. So again, current evidence does not support routinely discontinuing buprenorphine before surgery. It is also a powerful analgesic in and of itself and can be combined with other opioids. So we have buprenorphine on board first and maintained. And this is a nice article about this from 2018 from Dr. Lemke and colleagues out of Stanford that really outlines it nicely. And I think if you ever wanted to pull up this article, there's also a nice kind of template for addressing perioperative care. So we'll talk briefly about naltrexone and acute pain management. So again, naltrexone having that high binding affinity, also to the mu receptor, but being an antagonist at the receptor. And for that reason, we want patients to carry an alert card to inform medical personnel in the case of emergency, especially if they're taking injectable naltrexone because of a long-lasting effect. So a suggested plan for pain management would be regional anesthesia and the use of non-opioid analgesics if possible. But in an emergency situation requiring opioid analgesia, again, that opioid on top may be a greater requirement than usual. But also the resulting respiratory depression could be deeper, more prolonged. So patients really need to be continuously monitored in that case. And opioid treatment should be provided by individuals who are specifically trained in the use of the anesthetic drugs. So rapidly acting opioid analgesic that minimizes duration of respiratory depression is preferred, and patients should be closely monitored again. This slide is just comparing again the difference, similarities and difference approach between methadone and buprenorphine. Again, in methadone, just to summarize, we're confirming that dose, continuing the regular dose, but if not able to confirm it, best to divide the dose, and if not able to confirm any, also to not give more than 20 to 40 milligrams on day one, decreases the chance of respiratory depression. And then provide additional short-acting opioids if indicated. At discharge, it is helpful to provide a last dose letter, and at OTPs, we are required to check with the hospital what that was. And then for buprenorphine, again, we're going to go with the second, the continuing buprenorphine, hopefully, and use additional buprenorphine as needed, or full opioid agonists to cover acute pain, maximizing our non-opioids and possibly dividing that buprenorphine dose, rather than the top option here, because this top option of stopping buprenorphine, the concern is that having to plan later for restarting Suboxone can increase someone's risk of a relapse. So I'm not going to read through this slide, but this is also summarizing the treatment with buprenorphine, methadone, and naltrexone, and the perioperative considerations, what you would consider both pre-operative, the day of the surgery, and post-op for care. And this is a slide kind of outlining the non-opioid pharmacologic agents for multimodal analgesia that may be options to help with pain as well, ranging from ketamine, to clonidine, lidocaine, and your NSAIDs. Again, here's a table showing so multimodal pain management approach, and certainly to remember as well that there may be some other therapeutic options outside of medication, such as mindfulness, that can help decrease someone's experience of pain. So now we're going to turn to chronic pain management. And I'm just looking at the time here, just checking also the chat. I don't think, unless anyone has let Rachel know, if we don't have a case, I'll try not to race quite as fast through these slides, but if we do have a case, please do put that in the chat, and I want to make sure we give it adequate time. This is also, I think, a slide from online of a patient who's experiencing chronic pain and how distressing that experience has been for them. So some basic considerations. Remember that a history of opioid use disorders is the single biggest predictor of aberrant use of prescribed opioids. So certainly getting a good history is key. Considering consulting a patient pain management specialist, especially in such a case. Use a multidisciplinary team approach. So as much as you can, having different providers, peer support involved in care is key. And try to use, if not contraindicated, a non-opioid adjuvant medication first, such as NSAIDs, SNRIs, TCAs, membrane stabilizing agents, gabapentin, pregabalin, and then also again using our non-pharmacological therapies. CBT for pain has a large body of evidence, acceptance and commitment therapy as well, or ACT. And then if patient is willing and can access yoga, meditation, pool therapy can be quite beneficial, acupuncture, traditional healing, etc. And then also employing your interventional approaches. So if a TENS unit, trigger point, etc. could be helpful. And then just to talk about responsible opioid prescribing, this is something that, we fortunately have been reminded of a lot now, but in response to, the 90s of where it was quite a big increase in opioid prescription, we need to consider how we as prescribers can affect someone's risk. And so we want to remember someone's individual risk factors, again, with that prior mention of the biggest risk factor being a prior history of substance use disorder. It's not an absolute contraindication. We still want to appropriately treat someone's pain, but just want to be very careful in doing so. So we want to use our screening tools to make sure that we are adequately assessing for that, monitoring for any concerning use of prescriptions, and then using our urine drug screens, PNP monitoring as a tool, not to discharge someone from care or anything like that, but to really have a closer understanding and more engagement in treatment if they are struggling. Those can be some tools that objectively can give us some information. Remembering our treatment agreements and always co-prescription of naloxone. So here's a vignette where someone who has chronic pain and was started on buprenorphine. This is a 55-year-old female who presented for treatment of her substance use disorder. She had a 12-year history of chronic pain following an ATV accident and a pelvic fracture. And she's had gradually increasing doses of opioids up to 300 MMEs per day. She has had concerns with buying off the street and going to multiple providers. She's had worsening problems with marriage, work, relationships, worsening depression and anxiety, and states that her pain is all over and worse than ever. She started on buprenorphine and at a dose of 4 milligrams 3 times a day. So that split dose kind of reflecting the treatment of the pain. In addition to OUD, she reported improvement in pain, that she felt happier. She was functioning better at her work and has stated that she has her life back. So if chronic opioid analgesics are required for pain control, buprenorphine can make it difficult to get analgesia from full mu agonists because of its high affinity to that receptor. And it may need to be discontinued as a result. But in a subset of patients with chronic pain and a history of OUD may experience a reduction of pain and abuse. This is sort of old language from this article, liability with buprenorphine maintenance, and divided daily dosing may be needed for analgesic control. So certainly there's also some possibility that patients who are on higher dose opioids may experience hyperalgesia from those full agonists, and there may be some mitigation of that worsening pain when they transition to buprenorphine. Here are some reasons why buprenorphine might be a good option as a frontline analgesic. It's been shown to be effective for cancer pain, for neuropathic pain. It treats a large array of pain types. It tends to produce less constipation. However, it's still important to proactively address that because many patients do experience it. Key that it has that ceiling effect on respiratory depression, so very hard to overdose. Causes less cognitive impairment and isn't immunosuppressive like morphine or fentanyl. There's also less concern about QT prolongation. It's safe in renal failure and effective in the elderly. Withdrawal may be milder, especially if it's tapered down. There are some patients who have experienced severe withdrawal from especially stopping it abruptly, so important to keep that in mind. And then this slide is showing how that hyperalgesia effect can be potentially alleviated. So you can see these are the morphine morphine equivalents ranging anywhere from 200 to over 1,000. And the blue is their pain before transitioning from high-dose opioids, and their pain once they've transitioned to buprenorphine in red. And you can see that there's a significant drop in their pain score. So that goes to support that there may be some alleviation of that hyperalgesia. And then sublingual forms aren't approved for treatment of chronic pain, but they can be quite effective. Buprenorphine patch is approved for treatment of chronic pain. And you can see here 5 micrograms per hour up to 20, up to 7 days. And the opioid naive, it would be decreased to 5 micrograms. And you can augment with opioid and non-opioid analgesics. I think there's one more vignette here just to kind of give an example of these presentations. So a 64-year-old female presented to the ER with dysuria. She was found to have advanced cervical cancer with local metastasis. They identified a need for pain management and also expressed concern about her history, 30-year history of heroin use and concerns about injection drug use. She was started on methadone and carefully titrated up at an OTP, placed on short-acting opioids for breakthrough pain, and importantly, there was close collaboration between the providers at the OTP and her oncologist. So in some cases, a patient's opioid use disorder may be better treated with methadone maintenance. Sometimes the structure, the full agonist effect may be more helpful than buprenorphine for certain people. It also avoids the complications of a possible precipitated withdrawal that we see often with buprenorphine, and may in some cases provide more analgesia. And then for naltrexone in chronic pain, patients who have chronic pain who may require opioid analgesia aren't good treatments, obviously, for treatment with naltrexone, since it blocks that receptor. So you'd want to consider using buprenorphine or methadone. And that brings us to the end of the slides.